Okay, good morning. My name is Kathryn Stam. I'm a nurse practitioner, and I just want to thank you for joining me for this outbreak session on postpartum reproductive health care. So I have no financial disclosures to report, but I do want to acknowledge some special people who helped make this presentation possible. First of all, Jody Cran is a nurse practitioner and colleague of mine here at Planned Parenthood of Wisconsin. She and I collaborated on the development and implementation of postpartum services in the family planning centers throughout Planned Parenthood clinics in the state of Wisconsin. I also wanted to give a shout out to Dr. Wickman and the Periscope Project out of the Medical College of Wisconsin in Milwaukee and the amazing work they're doing to support perinatal mood disorders and help support providers with coping with that difficult topic. And also I wanted to acknowledge the International Society for Sexual Medicine, who graciously allowed me to utilize some of their slide deck today. And this is a great resource for anybody who's interested in more information regarding sexual health. So our objectives today are going to increase the comfort in providing postpartum care, and we'll start by defining the postpartum period, identifying the physical, social, and mental health needs of your postpartum patients. And then in the second part, we're going to really dig into sexuality concerns, so dyspareunia, the who, what, why. We're also going to analyze the benefits of pregnancy spacing and address the needs of contraception. So for full disclosure, this is not a comprehensive overview on the provision of postpartum care. It's not going to make you an expert in that, but hopefully, like I said, will just increase your comfort level. If anybody is interested in more information about the physical components of a postpartum exam, which are outside the scope of this presentation, I'm more than happy to share that with you. And my contact information is located at the end of the presentation. And I also want to take personal responsibility for some of these slides being a little busy. They're jam-packed full of content. I just want to recognize that everybody comes forward with a different level of experience and expertise. And so if this is a topic you're already familiar on, awesome, breeze through it. If it's something that you really want to dig into, I hope I have the resources to support that. So let's get started. What is the postpartum period? So the World Health Organization points out that there's no official definition, but it's traditionally identified as the 6 weeks following a birth. And the postpartum period is sometimes referred to as the 4th trimester because it can start within an hour after delivery of the placenta and continue up until that 6-week period. And this is a time that underscores the physical and emotional health care of new mothers. And there are 4 vital issues that are going to be assessed at the time of your postpartum visit. We're going to look at medical complications, breastfeeding, social health issues, including postpartum depression, sexuality, contraception, and preventative screening services. So why is postpartum care important? Well, we know that 70% of postpartum patients are going to describe at least one physical problem in the first year following delivery, and 25% of those problems are considered moderate. We also know that 40% of patients don't attend their postpartum visit, and this can be related to several different barriers, such as lack of childcare, inability to get an appointment, mistrust of their healthcare providers, and limited understanding of what the postpartum visit is. And we also need to recognize the limitations put in place by the current COVID outbreak. Some of these barriers are accentuated into low resource populations as well. And so our goal is to optimize postpartum services to create an overall feeling of health and well-being for our clients. So why would a patient come to you for postpartum care? Well, maybe you're already seen as a trusted provider. They may have seen you for a pregnancy confirmation visit, or maybe they've seen you for annual exams or birth control in the past. Perhaps this client can't get an appointment with their delivering provider because they're no longer available or it just doesn't meet with their schedule. Patients are often accessing community health centers in search of contraception during the postpartum period, and perhaps they see this as their comprehensive postpartum visit, or they may lack access to care due to insurance changes or location, or again, concerns with COVID. And I always just like to point out that whenever a woman gives birth, not only is a baby being born, but so is a mother. And so how we treat people at this postpartum visit could affect how she feels about herself, not only as a parent, but also as a woman. And so kind, thoughtful, patient-focused care is going to increase the chance that this client's going to come back to you for problem visits or annual exams in the future. So let's get started looking at care of the postpartum patient. And again, this visit would occur approximately 6 to 8 weeks after delivery. Ideally, you're going to have access to prenatal, delivery, and postnatal records for this client. And if not, try to request those records before your visit. I would encourage you to pay close attention to the delivery summary, the discharge summary, and an updated medication list if possible. If no records are available, don't sweat it. You can do a detailed past medical and surgical history and a comprehensive review of systems to get to the information that you need. So you'll want to focus on the route of delivery and if there are any complications following the birth. Ask about bleeding or discharge since delivery, if the client is breastfeeding, any abdominal or perineal pain, change in bowel and bladder function, contraceptive history, so what worked for them and what didn't. Evaluate their reproductive life planning, so when are they planning for another pregnancy, if ever, and depression screening utilizing the Edinburgh Postnatal Depression Scale or similar tool, which will be discussed later on. You're also going to want to keep in mind that it's important to update the vaccination history. So postpartum maternal vaccination can prevent infections in both your patient and their infant, because if they're breastfeeding, they can acquire those maternal antibodies through the milk. And keep in mind that all vaccines, with the exception of smallpox, can be given during breastfeeding. And in Wisconsin and the Midwest, we do have high rates of whooping cough, and so you'll want to update the Tdap booster if they're eligible for that. You're going to do a screening for sexual and social history, safety and intimate partner violence screening, and you're going to inquire about childcare. Do they have a pediatrician? Are they utilizing safe sleep practices on a car seat when they're out and about? And do they need additional resources from WIC or family planning services? So the postpartum physical exam components include evaluating vitals, thyroid, breast, abdomen, pelvic, and extremities. And again, it's outside the scope for this presentation to really dig deep on the physical findings, but I'm happy to share that as mentioned before. And what I'm going to do now is just kind of do a brief overview if you were the person to be doing the intake for this visit, what kind of questions you would want to be asking. So for the breast exam, no one's expecting you to become a lactation consultant overnight. You're just going to want to follow the breast cancer screening guidelines that are set in place for cis women and trans men, which are listed here. It's also important to recognize that the effects of lactation will recede approximately 2 weeks after delivery if this client has decided not to breastfeed. And having a helpful resource network handy if you as a healthcare provider or clinician are not comfortable in doing lactation support would really come in handy, and I'll give you some resources on how to do that coming up. So for your breastfeeding folks, you're going to want to coach her and praise her on any breastfeeding attempts. And again, have that referral network handy for problems. If your client has decided to formula feed, discourage any feelings of guilt she may have if she expresses that, and just reassure that they're making formula appropriately. So following the recommendations based on the Food and Drug Administration and the American Academy of Pediatrics. So this slide just depicts a list of resources that you can utilize either by typing in your own zip code or clinic location, and it'll help you develop a referral network from La Leche League or WIC and Wisconsin breastfeeding resources. If you're someone who likes to learn by podcast, this is a great one by Dr. Bodnar and Dr. Iglash. And so it's free wherever you would download podcasts, and they do updates monthly. And it would be remiss not to talk about COVID, okay? So Full disclosure, this presentation was created in early July, and so we did utilize the most up-to-date research at that time, but COVID is constantly changing and our information level is changing. So just check back with the CDC website often for updates. But as of right now, breast milk is still considered to be the best source of nutrition for most infants, and the decision to start or continue breastfeeding if a woman tests positive should be a collaborative decision between the client and her healthcare providers. There has been a small study, so you can see this case that's listed here by Walker included 666 COVID positive mothers. Of that almost 700 population, only 4% of those neonates tested positive. Okay, 7 of those babes were breastfed, 3 received formula, and 1 received expressed milk through bottle, and 7 babies did not have a reported feeding route listed. And so why is this important? Well, we just want to say that as of now, it looks like transmission is related more to the droplets that happen during that close contact with breastfeeding and not necessarily through transmission in the milk itself. And we'll discuss that again on the next slide. But if a mom were to test positive, ideally separation or isolation would be recommended with the understanding that that's not always possible. And so you would want to try to reduce the risk of transmission by using a cloth face mask whenever she's in contact with the baby, especially with nursing, otherwise maintaining a 6-foot distance. And please, please, please don't put a face mask on a baby. And so can the virus be transmitted through milk itself? So looking at the U.S. Centers for Disease Control and Prevention, the American Academy of Pediatrics, and the World Health Organization, they're still advising folks that there is a possibility of droplet precaution while breastfeeding, but the potential exposure through breast milk itself is unknown. So Chambers et al. Did have a small study that was just recently concluded. It looked at 64 samples of COVID positive moms, and in that sample, only 1 sample had detectable RNA virus in the milk itself. And so it's unclear if that sample was contaminated by droplets during the collection or if it actually existed in the milk. What we do know is that these babies did not have any increased severity in their symptoms, and they were not more likely to become seriously ill. The other interesting thing that took place in this study was that Chambers spiked healthy milk. So they took healthy milk from negative moms and introduced COVID particles into the milk and then pasteurized it. And this did completely kill the virus. And so this is something important to consider for folks that are using donor milk, whether in the situation of an ICU or adoption or just for personal preference. And again, I'm sure there's more information to come, so just keep checking back. The next component, we're moving on from boobs to bellies. And so looking at the components of the postpartum abdominal exam, this will involve muscle tone, diastasis, and any inspection of a surgical delivery or tubal ligation site. So during pregnancy, the growing uterus is stretching and the abdominal and back core muscles get stretched. And sometimes that abdominal wall will remain soft and kind of poorly toned for many weeks, but it should regain most of its muscle tone over the next couple weeks, but a persistent separation or diastasis may exist. And this typically will resolve on its own with maternal exercise. So again, this slide lists the components of the postpartum pelvic exam. So it lists the different structures that would want to be evaluated during that exam. And I wanted to touch on lochia. So lochia is the postpartum vaginal discharge that contains blood, mucus, and uterine tissue. This type of discharge can continue for up to 6 weeks after childbirth. It will start as lochia rubra, typically like dark red appearing menstrual flow. And then over a period of weeks, the discharge is gradually going to become lighter in color and amount, so gradually transitioning into this lochia serosa, which is pinkish brown, and then lochia alba, which is lighter amounts of a whitish yellow discharge. And so this fluctuation is kind of a normal change. But any patients who have complaints of abnormal vaginal discharge should be evaluated. And so what would abnormal discharge be? Well, anything that is purulent or green, if it's foul smelling, if it's urine-like or stool stained, or if the client just feels like it's an increasing in volume, they should have a pelvic exam. Causes of abnormal vaginal discharge are listed below. And since we're in the neighborhood doing a pelvic exam, you'll want to pay attention to the GYN screening guidelines. And so follow the cervical cancer screening guidelines set in place by the American Society for Colposcopy and Cervical Pathology. You'll also want to evaluate for STI screening based on individual risk and the CDC guidelines. And again, like we talked about, evaluating for any abnormal vaginal discharge. Okay, so now we're moving on from the physical components to the social history concerns. And in this piece, we're going to look at postpartum depression, tobacco, alcohol, and drug misuse, intimate partner violence and safety, the importance of diet, exercise, and nutrition, patient support for feeding and going back to work if they choose to do so, and infant care practices. So we'll start with a discussion of postpartum mood disorders. Postpartum depression has been referred to the thief that steals motherhood because symptoms can interfere with the mother's ability to care for herself and her family. If postpartum mood disorders are left untreated, they can result in severe consequences for the mother and the family unit. And the identification of postpartum depression and mood disorders rests in the hands of you, the folks that are seeing these women throughout the first year postpartum. And you are well equipped to help folks deal with postpartum mood disorders because you actively listen and acknowledge patient experiences on a daily basis. It's important to remember that women may be fearful to reveal how they truly feel due to shame or social stigma, so we need to ask. So postpartum depressive mood disorders can be broken down into 3 basic groups, and this is by no means exhaustive, okay? So perinatal mood disorders could be its own separate breakout session. Hint, hint, nudge, nudge, maybe for next year. But just to break it down into 3 basics, you're gonna see the postpartum blues, which is very, very common, affecting 50 to 85% of women in the first 2 weeks postpartum. These symptoms are pretty mild and they tend to go away on their own. We'll progress on to postpartum depression, affecting about 13% of mothers in the first year. And symptoms can fluctuate. They can be moderate or severe. They could have a short course or a long course. And then lastly, postpartum psychosis. So this is rare and severe. This is considered a psychiatric emergency and will often require hospitalization. So how do we screen for postpartum depression? Well, the Edinburgh Postnatal Depression Screening Scale, or the EPDS, is the most widely used instrument to screen for postpartum depression. It's a self-report 10-item scale, which can be easily completed in less than 5 minutes. This scale is acceptable to most women and clinicians because it's so easy to score and it's available in over 50 languages. So the 10 points are scored either 0, 1, 2, or 3 with a maximum score of 30, but a score equal or greater to 12 will identify most women with a major postpartum depression. And this is an example of what the scale would look like. It is typically completed on paper prior to you seeing the patient. And the reason for this is research tells us that folks are a little bit more honest with a self-report tool as opposed to verbal questioning. It might be a lot easier just to check a box and say, you know, sometimes I'm thinking of hurting myself instead of saying it out loud. The other benefit of completing it on paper before you see the client is it lets you know what you're walking into. So you can review the score, and if somebody is scoring high or if you have concerns, you can walk into that visit and already have a follow-up plan in place or a referral in place for this client. I would like to draw your attention to number 4 and number 5. I have been anxious or worried for no good reason, and I have felt scared or panicky for no good reason. A combined score greater than 7 on those 2 points is indicative of a postpartum anxiety disorder. And so if you have an elevated score on those 2 points, it would be a great idea to follow up with some leading questions. It seems like maybe you're feeling a little anxious. What helps you deal with that anxiety? Do you feel like your anxiety is keeping you from doing some of the things that you need to do during the day to care for yourself or your baby? How does that anxiety feel physically? And that will help you to determine the extent of her symptoms. I also want to talk about number 10. The thought of harming myself has occurred to me. And so don't beat around the bush with this one. If you have an affirmative score, we need to talk about it. Okay. And so asking this patient, so you've had some thoughts of hurting yourself. Do you have a plan? What would you do? And so this is going to tell you if maybe this client is like, oh, I would never do anything. I just sometimes just feel so burned out. I just don't know what to do. Or maybe they would say, well, I know my husband has a gun and I know where the case is, or, something like that. And if they have a plan, follow up on that. So what keeps you from acting on that plan? And so the degree of severity of if this is an active or a passive plan will help you to determine the risk of self-harm and the need for emergent referral. So when should we be doing this screening? Well, according to the American College of Obstetrics and Gynecology, patients should be screened at least once in the perinatal period, but most experts believe that this is not enough. You're going to want to consider screening for the psychosocial adaptation to parenthood between 2 and 4 weeks postpartum, in addition to the 6-week postpartum visit. And if you're lucky enough to get to see this person around 12 weeks, do it again just to see if anything's changed. And you may want to consider doing this screening anytime during the first year postpartum, because we know postpartum mood disorders can occur anytime in the first year postpartum. So treatment will typically be done by referral and would include perhaps peer counseling, cognitive behavioral therapy, and antidepressants, or ideally a combination all of these things, in addition to some self-care and sleep hygiene techniques. Anticipatory guidance may be helpful as far as what this client can expect. And follow-up is paramount. Screening is great, but it doesn't really do anything if it's not paired with appropriate follow-up and treatment when indicated. And so you're going to need to have your referral network on hand for when this patient presents to you in clinic. And how can you create a referral network? Well, we're very fortunate in the state of Wisconsin that we have the Periscope Project. So again, out of the Medical College of Wisconsin in Milwaukee. And again, thank you to Dr. Wickman for her amazing work for perinatal mood disorders. So the Periscope Project is a free resource for healthcare providers who provide care to perinatal women who are struggling with mental health or substance abuse disorders. And how does it work? Well, it's a real-time provider-to-provider psychiatric consultation. It also allows you access to educational presentation and tools and some continuing education, as well as providing community resource information. So the Periscope Project works. I'll give you an example. So I am a nurse practitioner, and let's say I am seeing a client in clinic who reports a history of illicit drug use while she's breastfeeding. And so I can call the Periscope Project. I'll talk to the triage nurse and explain my clinical situation. And then she relays my message to the perinatal psychiatrist who's on call. That perinatal psychologist will then call you back, and return call time is typically about 6 minutes. And then the two of you can have a one-on-one conversation talking about your concerns for this patient, and your consultation will also include resources and support. And so perhaps she'll give me the risk of using these certain drugs during lactation, and she'll also provide me treatment options and maybe local AODA resources for my specific community. And then I can turn around and relay that communication directly to the client. And because the turnaround time is so quick, you have your consultation while the client is still in the office. So they can leave with something tangible. They can leave with a referral and a plan of care that's in their hand. So to enroll in the Periscope Project, you just need to be somebody who works with patients who are pregnant or postpartum. The enrollment process is very easy online. The website is listed here, or you could call and enroll over the phone. I do recommend enrollment before you need it, just because it speeds that process up a little bit for you when you're in the throes of dealing with a complicated patient. And so in addition to the Periscope project, this slide just lists some other local resources that you could reach out and find who's specific to your community. And a complete social screening will also be part of your postpartum exam. So you're going to want to include screening for tobacco, alcohol, and drug misuse. And we know that nicotine is a major modifiable risk factor in the United States, with 17% of women smoking regularly. And this does increase the risk of harm to their infants. So increased risk of SIDS, or sudden infant death syndrome, asthma, and the effects of secondhand smoke. And we also know that alcohol and drug misuse can really affect the family unit as well, causing impaired parenting, depression, and the associated mental health disorders that could go along with that, risk for future pregnancy, poor decision-making, irresponsible behaviors, poor nutrition, homelessness, joblessness. And it's important to keep in mind that breastfeeding would be contraindicated with heavy alcohol use or illicit drug use. I just wanted to touch quickly on the importance of screening for intimate partner violence as well. And so intimate partner violence affects 23% of people throughout their lifetime. And it's important to do this screening during pregnancy just because it's a high risk time for folks. And so start with a framing statement. Say, we ask all postpartum patients about their safety because it can have a huge impact on your health. And again, if you have your referral network kind of handy, you'll be mentally prepared for what to do with an affirmative response. Again, pulling this into the time of COVID, sorry, my mouse is acting all wonky there. You have to keep in mind that we're encouraging people to isolate and stay home, but not everybody is safer at home. And so asking, do you have any concerns about your safety? Or if the client seems hesitant to answer, address that. Say, you seem a little bit reluctant to talk about this. Is there anything that I can help with? Or is there anything that's concerning you right now? And just reach out to the domestic violence hotline or the National Sexual Assault Hotline if you need additional resources. I will submit a handout for you guys as well to review about IPV. Okay, so moving on to postpartum sexuality. So we're going to touch on dyspareunia, pregnancy spacing, and contraception. So when can people be sexually active again? Well, there's not a clear-cut timeline for this, but it's generally accepted to wait to be sexually active vaginally until the perineum is fully healed, the client is emotionally ready, and they're using contraception if they desire to do so. And these things have typically occurred by about that 6-week postpartum visit. So the lochia and vaginal discharge will have ceased. If there were any perineal lacerations, those are going to be well healed, sutures are going to be reabsorbed, etc. So female dysfunction during pregnancy and postpartum. So childbirth is a central event in women's reproductive life, and sex is normal and healthy during pregnancy and postpartum period. But how a woman experiences sexuality during this time can change. Again, only 15% of women are going to discuss sexual problems with their healthcare provider, so it's important that we ask. So what physical factors could affect sexual activity? Well, the first off is going to be dyspareunia. And so dyspareunia is defined as genital pain that occurs just before, during, or after intercourse, and can have both physical and psychological factors involved in that. We know postpartum depression is reported in 50 to 60% of patients at the time of their 6-week postpartum visit, but it also is reported by 30% of women at 3 months postpartum and 17% of women at their 6-month postpartum visit. And so risk factors for dyspareunia would include infection, operative vaginal delivery, so forceps or vacuum delivery, a 3rd or 4th degree vaginal laceration, wound separation, pelvic organ prolapse, or breastfeeding. And when dyspareunia happens after childbirth, it's really important that we address it, just like you would address any other health concern or complication. And so if these sexual health concerns aren't addressed and managed, they could lead to long-term physical and psychological difficulties, not just for the woman, but for her partners as well. Again, the route of delivery may have an effect on postpartum sexuality, with a planned primary C-section showing the lowest rates of long-term sexual dysfunction, and an operative delivery, such as forceps or vacuum, associated with the highest rates of dyspareunia. There are several postpartum factors to consider that may affect the function of the psychological, behavioral, and cultural factors. And so remember that women may be hesitant to openly discuss these sexual health issues. And so it's really important that you ask about how your transition to motherhood is going and provide reassurance and encouragement when necessary. So postpartum sexuality is also multifactorial. It's not just based on things healing and getting back to a pre-pregnant state physically. It could depend on several other functions as well. Breastfeeding. So breastfeeding can play a part in postpartum sexuality. Vaginal atrophy happens due to the hypoestrogenic state during breastfeeding, and this can lead to inadequate vaginal lubrication or dyspareunia, as well as a decreased arousal response. It's important to acknowledge that some women may leak milk with orgasm. They may have increased nipple sensitivity with foreplay. Addressing that erotic feelings can happen when you're suckling your baby, and oxytocin can cause intense uterine contractions, which for some folks could be considered arousing. So address that these things happen and are normal and provide reassurance. When you're addressing sexual function, you're also addressing the need for referral or counseling, and these slides just depict what may happen in a counseling situation. And so now that we talked about sex, we should probably talk about contraception and maybe some pregnancy spacing. And so we know that the first ovulation can happen as soon as 45 days after delivery in a non-lactating client. And 66% of people report being sexually active during the first month postpartum. And so if you wait to have a talk about contraception until that 6-week postpartum visit, it may be too late. So we'll start by looking at interpregnancy interval. So interpregnancy interval is defined as the spacing time between one live birth and the start of the next pregnancy. And so in 2019, there is an obstetrical care consensus. And so this statement was endorsed by the American College of Obstetrics and Gynecology, the Society for Maternal Fetal Medicine, the American College of Nurse Midwives, and also the Association of Nurse Practitioners and Women's Health. And so they stated that women should be advised to avoid an interpregnancy interval of shorter than 6 months due to increased risk of adverse pregnancy outcomes, and that women should be counseled about the risks and benefits of repeating a pregnancy sooner than 18 months. And so most of this data on pregnancy spacing came from observational studies in the United States that suggest a modest increased risk of adverse events for the mother and also the babe when those pregnancy intervals are less than between 6 and 18 months. And those are listed here on this slide. The other thing that's interesting is that they identified a short interpregnancy interval as being somewhat problematic, but they also reported a long interpregnancy interval as being equally concerning. So if you're spacing your pregnancies by 5 to 10 years, that's also slightly elevated risk for adverse outcomes. So wait a little bit, but not too long. Where did these definitions come from, and why do we think that there's concerns here? Well, again, a short interpregnancy interval would be defined as anything less than 18 months between delivery and the onset of a new pregnancy. Okay, and looking at CDC data from 2015, so this report included data from 36 states and showed that 30% of women have a short interpregnancy interval, and for this case it was defined as less than 18 months, with this occurring more often in teenagers and folks that are delivering in their 20s. They hypothesized that adverse outcomes could be related to three different hypotheses. So the first is according to the maternal depletion hypothesis. Maternal nutrients, particularly folate, may not be replenished sufficiently during closely spaced pregnancies. And this is especially noticeable in folks that are breastfeeding. And then that leads to the adverse outcomes, specifically growth restriction in this case. The infectious process hypothesis, it's believed that there may have been a residual genital tract infection or inflammation from one pregnancy that may not have completely resolved by the time of the second pregnancy. And so this low-grade infection increases the risk for premature rupture of membranes or preterm labor and then subsequent preterm birth. And other factors that may relate to some complications related to a short interpregnancy interval could be related to cervical insufficiency, sibling competition for maternal resources, transmission of infection between closely spaced siblings, and incomplete healing time of a uterine scar from a previous C-section. So the long interpregnancy interval, again, is typically described as longer than 40 months, and this occurred about 30% of the time. Most common in women that were between 30 and 44 years old. And adverse outcomes in this group are thought to be related related to a physiologic regression hypothesis. So the theory is that pregnancy causes important time-limited changes and adaptations, such as increased blood flow to the uterus and things like that, that eventually, if too much time passes, that's no longer available to folks who have a longer interpregnancy interval. So postpartum emergency contraception. Well, I guess just to take one step back, I'm sorry. So when we're looking at pregnancy goals, and especially pregnancy spacing, it's important to keep in mind that this is a personal choice, okay? So our job is to provide folks with the best information and allow them to make the best choice for them and their family unit, okay? And so if you're having a conversation about pregnancy spacing, it kind of leads into the next topic of contraception. And so if you know someone wants to space their pregnancy out by several years, maybe a LARC is better. If they're thinking about having a pregnancy in another year, maybe something that's more easily reversible would be a better fit for them. Okay, now we'll move on to postpartum emergency contraception. Thank you for your patience. So unprotected intercourse or contraceptive failure before 21 days postpartum does not require emergency contraception. There are three types of EC. Two are pill formulation, and the third is the Paragard IUC. The Paragard can be inserted for emergency contraception beginning at the 4th week postpartum, or really any time that you can be confident that this patient is not pregnant. And just for review, emergency contraception works by disrupting the timing of ovulation or by preventing fertilization of the ovulated egg. It is not an abortifactant or an abortion-inducing drug. So this slide depicts the two forms of oral emergency contraception. So on your left, you're going to see LNG, which is a synthetic progesterone. And so the primary mode of action here is prevention of the LH surge. It's reducing pregnancy risk by 75 to 89% when used within 3 days of unprotected intercourse. Research is kind of mixed, but it does suggest that the serum LNG concentrations do start to decrease at a BMI of 25. So just keep that in mind. And this form of emergency contraception is safe for your breastfeeding clients. UPA-EC, or commonly known as ELA, is a selective progesterone receptor modulator. And so this mode of action is to prevent the LH surge and prevent follicular rupture. Okay, this is the most effective form of oral emergency contraception for unprotected intercourse in the last 5 days, and it is not BMI dependent. However, the caveat to this is you would want to caution your folks to pump and dump if they're breastfeeding for 36 hours after that dose of ELA. Copper EC could also, the copper IUD could also be used for emergency contraception, and this is the most effective form of emergency contraception when placed within 5 days after unprotected intercourse. So first cycle pregnancy rate after placing an IUD is 0.1%. And so the copper works by disrupting the sperm and ovum function to inhibit fertilization. It alters the physiology of the uterus and the tubes and prevents implantation. This can also be used for LARC and as well as emergency contraception because it's effective for multiple acts of unprotected in that same menstrual cycle and is highly effective regardless of BMI. Okay, so for choosing a method, you're going to want to remember method-specific recommendations for initiation and backup methods. You'll want to discuss with the patient the potential for decreased libido and change in natural lubrication postpartum as long as they continue to breastfeed if they are. And discuss that combined hormonal methods could potentially decrease the milk supply. Oops. So postpartum intrauterine contraception. So an IUC may be placed immediately after expulsion of the placenta or any time in the postpartum period as long as you're reasonably certain that this patient's not pregnant. So postpartum IUC. So an IUC may be placed immediately after expulsion of the placenta or any time postpartum as long as you can be reasonably certain that the patient is not pregnant and without any other special conditions or contraindications. As mentioned previously, the Paragard could be inserted for emergency contraception beginning the 4th week postpartum. You'll want to avoid placing any intrauterine device for 3 months after endometritis or a uterine infection, prolonged labor or ruptured membranes due to infection. Expulsion rates following an immediate postpartum insertion are going to be higher than those following interval insertion. And so if you look at the interval insertion rates for expulsion, that's about 4% versus post-placental placement is about 24%. And so just kind of counsel your folks on the risk associated for expulsion. And when you're placing the IUD, perforation risk is a little bit higher with lactation. So just be gentle, go slow, and you'll do great. Postpartum contraception for your non-breastfeeding clients. So just remember the risk of postpartum VTE or venous thromboembolism is 5 times higher during pregnancy, and it does remain elevated until about 6 weeks postpartum. And so it's generally recommended to hold off on combined hormonal methods, so methods that contain estrogen and progestin, until at least 3 to 4 weeks postpartum, but really ideally waiting until 6 weeks when those pregnancy-induced changes in coagulation have started to resolve. You're going to want to avoid using a diaphragm or a cap until the client is greater than 42 days postpartum due to increased risk of toxic shock syndrome when lochia is present and improper fit in the immediate postpartum period. Again, this slide just depicts the risk of VTE and when you may want to consider an alternative birth control method. And postpartum contraception for your breastfeeding clients. So you have options including non-hormonal options, so bilateral tubal ligation, a copper IUD, or barrier methods. Natural family planning or lactation amenorrhea are also reasonably reliable non-hormonal methods for some clients. And then hormonal. So again, combined hormonal methods are going to be contraindicated in that immediate postpartum period, and you're going to want to consider their other VTE risk factors. There are two types of hormones, so progestin only, so this would be your mini pill, your Liletta IUD, the implant, or depot shot, and so those are progestin based. They have no adverse effect on lactation and may even slightly increase the milk volume. There's been no adverse effects noted on infant growth and development with those. As far as combined hormonal methods, so the World Health Organization and the Centers for Disease Control did find a decreased duration of breastfeeding, and so they recommend delaying combined methods until the client is done breastfeeding. And there's no need to switch from a progestin only to a combined hormonal method during lactation unless it's her choice to do so. And in that case, it's best to switch methods after 6 months. I included the slide just to talk about melasma, or the mask of pregnancy. And so this occurs in about 75% of pregnant women, but it's important to keep that in mind for folks who are taking combined hormonal contraception, because they may notice a reoccurrence or a continuation of their melasma with combined hormonal methods. And then last but not least, lactation amenorrhea. And so this can be a very effective form of birth control for your breastfeeding clients. There are 3 key questions to ask to determine if lactation amenorrhea will be a reliable method of birth control for your client. So first, number 1, have your periods returned? Number 2, are you supplementing regularly, or are you allowing long periods of time to pass without breastfeeding, either during the day or the night? And number 3, is your baby more than 6 months old? So if no to all those questions, then there's only a 1 to 2% chance of pregnancy at that time. When one of those answers converts to yes, then there is an increased chance of pregnancy, and so you'll want to have the discussion about implementing a secondary or complementary family planning method in addition to lactation amenorrhea. Woo! We made it! So thank you so much for bearing with me and my little technical difficulties today. I am more than happy to address any questions or concerns that you may have. My contact information is listed here on this slide, and a complete list of my references are also available. And for anybody who is interested in more in-depth information about the physical exam components of the postpartum exam, I'm happy to share that as well. So thank you so much for your attention and your patience, and I hope you have a great day.